Thanks everyone for voting. I see we have a lot of researchers in the room, students, and some NGOs, so I think we're going to have a great discussion today.
I think there's a few people that are still scanning.
Oh, sorry. There you go.
Last chance before we start. Anybody want to scan? Okay. Yeah, we have them on the tables. So. Okay. Is everybody here okay in the back? Thank you all for coming. We know there's a lot of competing side events, so we really appreciate your coming to this one. We're going to be focused for the next hour and a half on water quality monitoring in emergencies and in waterborne disease outbreaks. And this is going to follow up a little bit on the session that was before lunch, where Bruce Gordon mentioned about guidelines and the proliferation of guidelines. But what we want to focus on here and for water quality monitoring is how do we increase the implementation? How do we facilitate implementation? So not going from guidance to actual action on the ground. So we've got a pretty packed schedule. So on behalf of, my name is Tom Hansel. I'm from the US CDC based in Atlanta. I'm with some colleagues here as well. On behalf of ProWash and Scale, U.S. Agency for International Development, Bureau for Humanitarian Assistance, and CDC, we welcome you to this side session. Last chance, anybody didn't get it? And we have one presenter who will be giving a recorded session. They were not able to make it. This is the agenda. I'm not going to go through it in details, but it's going to be a combination of presentations describing the problem, a desk review of some key gaps in water quality monitoring. We're going to give you 3 examples of water quality monitoring in different contexts of emergencies and cholera outbreaks. We are then going to give you a short time 2 activities that are underway now, 2 toolkits that are being developed. We hope will help address this problem. And then we're going to break up into small groups with specific topics that you'll get to vote on which ones, but we want to get some feedback from you to help us in the next steps. So we are going to be pretty tight for time, so we'll try to be as efficient as possible. And we have a really strict timekeeper here who's going to hopefully hone us in. So with that, Precious is going to give us our overview. Thank you.
Good afternoon, everyone. My name is Precious Sanko. I am a WASH advisor at USAID within the Bureau for Humanitarian Assistance. Water quality proficiency at BHA is a WASH sector global capacity priority. Water quality monitoring plays a critical role in public health by preventing the transmission of waterborne diseases such as cholera, dysentery, diarrhea. As a global community, we must continue to address the myriad challenges linked to water quality monitoring. For example, expensive and very much complex water quality equipment, limited awareness and ability to shift the local mindset towards water quality monitoring, as well as towards testing. Lack of access to professional laboratory facilities, limited data utilization for informed decision-making, as well as the ability to sustain water quality management plans in emergencies. As part of our global approach, humanitarian partners are empowering communities and governments through safe and climate-smart water and sanitation access. Some of their water quality activities range from raising awareness of basic water treatment practices at point of collection and use, to strengthening the capacity of community groups to develop water quality assurance tools such as water safety plans. In fact, the positive uptake of water safety plans is one example adopted by some communities to encourage routine monitoring and early warning prevention. Even with these successes, the sustainability of these efforts requires local stakeholder ownership, and local voices at the table. The current times come with unpredictability, visible climatic changes, and continuous population movements due to conflict and disaster. Knowing this, we will need to be very strategic in how we protect our waterways. As a WASH community, we will have an important role to play in the sustainability and quality of our water sources. In this workshop, we'll take a deep dive and hear case examples of partners, challenges, and opportunities to address water quality. We also look forward to engaging with you on resources, tools, and impactful solutions to address water quality in emergencies. So I will go ahead and hand it now over to Christian, who is with ProWash and Skill, to move us forward. Thank you very much.
Okay, thank you very much, Precious, and good afternoon, everybody. My name is Christian Snowd. I'm a global humanitarian WASH advisor with Save the Children, and I support ProWash and Scale with the work stream on emergency drinking water quality. I'm just going to provide a brief overview of our work so far. So last year, we started this work stream with 2 foundational research stages: a rapid document review and a sector stakeholder consultations. The purpose of these were to identify current strengths, challenges, and gaps being faced by organizations. And following this, we wanted to dive deeper into some real responses and to see if what we were learning was matching what was coming out from the ground, and to get a better idea of these challenges and where new resources might have value. So we did this through 5 response case studies that are currently being drafted. And following this, we're going to be developing practical guidance and tools and piloting them in humanitarian responses. So I'll share a bit about some of the main insights. So for the rapid document review, through a keyword search and through suggestions from the people we spoke to, we identified around 270 documents and information sources relevant to emergency drinking water quality that are freely accessible and openly available. So this included everything from guides, toolkits, web portals, research papers, and technical briefs. And in terms of just top-line observations, we found a lot of resources related to water quality standards and how to carry out water quality testing. Things from manuals to trainings or videos for the common tests and methods. But I think what was interesting to see was across such a large amount of resources, we found limited guidance on how to use and action water quality results and data in emergencies. And also, while there is some resources in sort of dense textbooks, we found a lack of accessible resources on broader water quality monitoring and planning. So going beyond just the what to test and the how to test. And while we didn't set out to create a bibliography from the start, given the amount of work that had been done going through all the existing resources, we picked out the key ones and published them into this annotated bibliography format earlier this year. So this guide to resources on emergency drinking water quality, it can be downloaded online. And we've also recently released a French version specific to French resources. And this is intended to be a live document, so we'll update it. If you know of new resources or resources that are missing or upcoming, please do let us know and we'll update it. So the other part of this initial investigation was the stakeholder consultations with key informants in the sector. So this was like key authors and emergency and development water staff, typically global heads of WASH. We consulted around 36 people from 22 organizations, mostly through semi-structured interviews, and we used a snowballing approach. So further key informants were added as recommended. And in terms of the most frequent challenges and gaps that came out from these consultations, they're shown here on this chart. Firstly, it was what we heard a minute ago from Precious as well around using data to inform decision-making. So stakeholders told us that data is generally being collected, but it's rarely being collated. and typically not being utilized in a timely way to inform actions and decision making. And second was around planning for water quality monitoring. So this means not just what to test and how, but also the why, the frequency, the sample sizes, managing risk, managing data. Third was around supply chain issues, particularly for local organizations that need to import supplies, and also around sustainability concerns, both in terms of sustaining testing as funding reduces over time, but also how to transition to longer term government structures. So following these initial investigations, we wanted to dive deeper into some responses. So with the support of the Global WASH Cluster, we selected 5 responses to include. Each of these is kind of a formal cluster sector representing and supporting a large number of WASH implementing partners. And in total, we conducted around 35 interviews, firstly with the cluster sector team, and then with the main implementing partners engaged in water quality monitoring. So these are being drafted at the moment to share back to partners, but we can already say that generally the findings are largely consistent with the global stakeholder consultations, but they offer further practical insights. The main challenge and theme that emerges, again, is around limited water quality monitoring planning. So while clusters are typically setting priority standards early in the response, only one country had guidance beyond that in terms of frequency. So this focus on what to test without further guidance on the how and the when and the frequency, sampling, etc., is leading to significant variation in approaches. And this is especially the case where representative sampling is needed. So where there's too many water points or too many households to be able to test them all. Similarly, sanitary inspections are commonly being used by emergency practitioners, but they're not commonly incorporated into sort of coordinated plans. So the frequency of them and the actions taken as a result varies significantly. And related to this, most of the people we spoke to requested more guidance on water quality monitoring planning in particular. So we also found most organizations don't have internal guidelines, and we only found specific project water quality monitoring plans where they were a requirement of a donor project, such as BHA. And regarding data, there was rarely coordination between partners, and typically there wasn't shared databases. And relating to supply, while it was highlighted during the stakeholder consultations that supply was a key issue, how this manifested was more in terms of delays. So we found that partners were able to get supplies, but often it would take 3 months. So on emergency projects, which can typically be 12 months or even less, this can be a key issue. And then the last thing to mention here related to these themes today maybe is around scale, and how scale plays a significant factor in shaping the responses. So in some responses, water quality monitoring might just be 5% of a WASH officer's job. But in other larger responses with centralized like large camps or where large consortiums have formed, we start to see dedicated staff, dedicated testing labs. So the scale and how it can be grouped plays a key role. So we're now going to look at 3 case studies, starting with one from Pro-Ocean Scale on Cox's Bazar, and then followed by 2 case studies presented by the CDC related to cholera prevention and response. So I think I got this right. Unfortunately, Tanvir couldn't be with us, so we're going to play a short recording that he prepared for us.
Hello, my name is Tanvir Ahmed and I work for UNICEF as the WASH Cluster Information Management Officer in Cox's Bazar, Bangladesh. I have been working on the Cox's Bazar Rohingya refugee response since the beginning 7 years ago. Let me share a bit.
This mic, is there another mic that might be picking up the sound?
Hello, my name is Tanvir Ahmed and I work for UNICEF as the WASH Cluster Information Management Officer in Cox's Bazar, Bangladesh. I have been working on the Cox's Bazar Rohingya refugee response since the beginning 7 years ago. Let me share a bit about the background of this response. Prior to the large influx of refugees into Cox's Bazar, rural water provision and quality in the area was managed by the Department of Public Health Engineering. Typically, the new water sources tested for chemical parameters as part of the commissioning process, while routine testing was minimal. In September 2017, 700,000 Rohingya refugees arrived from the Myanmar, and this is one of the fastest movement of people in recent history. This huge displacement put a huge strain on the local government, where almost 500,000 of Bangladeshis who also lived in the same area. A large number of international and national NGOs led the WASH response with the coordination support of the UNICEF-led WASH sector. During the initial phase of this response, more than 5,000 shallow tube wells were constructed to meet the water needs. The WASH sector adopted national standards for water quality should be followed with a focus on microbiological and chlorine testings and also attention on iron, manganese, and arsenic. Data from the initial phase showed that around 70% of the shallow tube wells are failing microbiological test, and the WASH sector promoted household chlorination and remedial actions of contaminated sources. When the response moved into the mid phase, NGOs developed dedicated fixed laboratories with increased capacities and dedicated staffs. Separate to the NGO-led testing, the DPEC, WHO, and UNICEF support to launch a water quality surveillance programs in December 2017. Test a random 10% of the constructed tube wells and 2 linked households for every 6 months. This program continued over 5 years. The surveillance results highlight the persistent microbiological contamination risk, and household testing was only finding chlorine residual in around 20% at the household level. The transition of pipe water networks. The WASH sector launched Water Master Plan in 2019 to construct 225 chlorinated water networks from production borehole to ensure chlorinated water at household level. These were constructed over the next 2 years in 2020 and 2021 and led to household with chlorine residual. In recent study shows that around 70% of the household are using tap stand as primary source of drinking water. Let's move with the data collection process. Since February 2019, partners have been submitting their water quality test data on a monthly basis. WHO, UNICEF, DPEC water quality data also have been archived in the same dataset, and we have developed an online interactive dashboard that displays all the data from implementing partners and third-party monitoring shared with the sector. This dashboard now contains around 1 million water quality results covering 11 parameters over the past 5 years. Overall, to wrap up, water quality has significantly improved thanks to pipe water services provided in the camps and using deep groundwater. Key water parameters, residual chlorine, E. coli, and turbidity are collected daily basis and regular basis for chemical parameters such as like iron, arsenic, and salinity. All the partners report under one dashboard all their water quality findings. Third-party monitoring seems crucial for water quality monitoring as we noticed significant disparities between own reporting and third-party monitoring. Thank you for the opportunity to provide a brief update on water quality monitoring in the Cox's Bazar Rohingya refugee response. We appreciate your time and for inviting the Cox's Bazar WASH cluster to participate in this conference.
Very sorry about the sound there. Thank you for persevering. Thankfully, we had subtitles, so hopefully if you weren't too distracted by the echo, you were able to follow some of what Tanvir was saying. It hasn't gone back to the correct mode. Okay. Firstly, I don't know if anyone caught that, but more than 1 million test results so far. It's crazy, right? After just 1 year, actually, the data volume was so large that it was crashing Excel. So now they had to move to multiple different Excel sheets and online dashboards just to manage the huge amount of data. One of the key lessons that Tanvir mentioned there at the end was the importance of third-party monitoring for this particular response. So there was this 5-year DPHE surveillance program looking at tube wells. And more recently, there was also third-party monitoring of the pipe networks. Just to have a quick look at that data, you can see there was significant variation. Like at the beginning of the response for the tube wells, you can see this large difference between what partners were reporting and what the third-party DPHE surveillance was reporting. And then on the right, looking at the tap stands from this year, actually, you can see quite a significant difference. So implementing partners reporting nearly 100% coverage of chlorine in the tap stands versus just over 50% through the third-party monitoring. But just to be clear, there's no suggestion here that partners are falsifying reports. And further investigation into this has highlighted certain potential reasons for this. But I think the key thing here is that without this third party, that would have been missed. So there's been quite a lot of value in this case of the third party monitoring, given the extensive scale of testing that's been going on. So this was an incredibly challenging scenario. By 2020, there were nearly 17,000 tube wells across the camps, just not feasible to treat all of them. And despite efforts, household chlorine use just didn't catch on to acceptable levels, similar to what was seen in the Rohingya IDP camps in Myanmar. But the availability and the compilation of the water quality data, it drove this change. So it drove the water supply plan, and it drove this quite bold decision to build over 200 pipe networks. And that's what led to this increase in chlorine levels in the household and increase in water quality. But similar to other emergencies, the standards of what to test were established quite early on, but further guidance on frequency, sampling size, risk inspections, that's actually coming out later this year. So just over 7 years after the response started. And again, this is a great response to look at for how data is being combined, but it did take nearly 1.5 years from the initial response for that to start happening. The lack of that consistent sort of water quality monitoring planning at the beginning has meant there has been a significant difference in approaches between partners, mainly determined by who the donor was. That's all we have time for now. We'll take questions later. So I'm going to hand over to Anu, who's going to take us through the next 2 case studies. And we don't have any more videos. Thank you.
Good afternoon. My name is Anu Rajasingham, and I'm a public health engineer at the U.S. Centers for Disease Control and Prevention. Our first case study, or the second case study today, but the first one I'm presenting, is an example of setting up a water quality monitoring system during a cholera outbreak response. And this occurred in Zimbabwe, starting in 2023 to 2024. And I want to acknowledge everyone on this slide because they were all very much involved with this program. And it was a collaboration between CDC, the City of Harare Health Department, Oxfam, and UNICEF. So some background to start. An outbreak of cholera began in Harare, or in Zimbabwe, in February of 2023. As of December 2024, there had been about 5,000 cases, and that's approximately when we started the water quality monitoring work. The outbreak was declared over in August of this year. The pipe network in Harare reaches the majority of the city, but because of issues with water quantity and water quality, which include frequent shortages and periods of high turbidity, other water sources are often used in Harare. These include boreholes, some of which have inline chlorinators attached to them, some on bush pumps, and some on submersible pumps. And in some areas, shallow wells are often used as well. The shallow wells we all assume to be contaminated. The City of Harare Environmental Health Department conducts water quality monitoring of both the pipe network and boreholes in the city regularly. The team has the mandate to do this and was conducting paper-based monitoring. Their existing system included a team of 6 people and 2 students, which is a very small team for a very large city. Their field testing included free residual chlorine, total chlorine, pH, and turbidity, and they conducted laboratory testing for E. coli and total coliforms. At the time, they were collecting approximately 20 samples per week. There's a few challenges with the paper-based monitoring system they had. First, there was delays in collation and analysis of the data, and there was delays in sharing the data with Harare Water, which was the water utility, and partners due to the delays in collation and analysis. The numbers of samples per week were also reduced because they were doing a lot of time processing the paperwork, et cetera, for the monitoring work. Due to the delays, the data was often not being used for corrective action. We worked as a collaborative unit, the City of Harare Health Department, CDC, and UNICEF, to improve this water quality monitoring system. The objectives were first to ensure the monitoring was used to inform corrective action, but to also ensure that whatever data collection methods we introduced would be sustainable even after the outbreak response. So the first thing we realized is we needed to pivot from paper to an online system, and we decided to use M-Water because the water utility, Harare Water, was already using the M-Water platform. So CDC developed M-Water data collection forms and dashboards for the city of Harare, and 2 dashboards were developed. The first one was for the pipe network, and this data was shared directly with the water utilities so they could see in real time the results the team was collecting. The second was one that tracked the monitoring results for boreholes and other water sources, and these results were shared with all WASH partners that were working across Harare. And it tracked things like inline chlorinator functionality, et cetera. Funds were eventually provided for additional monitoring and ensure sustainability of this improved system. And with the additional funding, we were able to expand sampling to about 70 samples per week. For the pipe network, the team monitored 72 sentinel points that they selected around the pipe network regularly. These are both points near the reservoirs and treatment plants where water was routinely dosed with chlorine, and further down the distribution network so we could get the full picture of what was going on in the pipe network. The dashboard summarized the data and created alerts if there was free residual chlorine that was 0.1 or 0 with exact locations both at the reservoirs and at the points of consumption. As a reminder, we like to see 0.5 milligrams per liter at the point of consumption during a cholera outbreak, and so that was our goal here. As I mentioned earlier, the results informed Harare Water directly. For the boreholes that were fitted with inline chlorinators were tested for free residual chlorine. E. coli and total coliforms were tested at boreholes associated with suspect cholera cases and at those boreholes without inline chlorinators. The team also had the mandate to routinely monitor water at healthcare facilities, schools, and larger community water points. Alerts for this section included when an inline chlorinator needed support, such as the chlorine sleeve needed to be replaced, or when there was E. coli contamination found at a borehole. So how was the data used? For the pipe network data, it was shared directly with the water utilities so they could see exactly what areas were getting lower than what was expected chlorine levels. It also helped identify areas that were routinely getting lower levels of chlorine. So it has identified 7 reservoirs where now partners, VAE, UNICEF, and CDC will be installing 7 booster chlorinators at those reservoirs to ensure that the chlorine levels are increased there. For the other water sources, such as boreholes, it informed WASH partners where to fix faulty inline chlorinators, or if there is a borehole with contamination, an area where a new inline chlorinator should be installed. So in summary, The strengthened monitoring system took about 2 weeks to establish. There was no initial budget to start, so there was a bit of a slower start as we got going. The main costs included transport so that the team, we got an additional vehicle for the team so the teams could split and go to different areas, internet for the office, tablets and laptops so the M-Water platform could be used by everyone. The results informed gaps in chlorination, such as where these new booster chlorinators will go and where faulty inline chlorinators needed to be maintained. The system has been well received by government, and they would like to replicate in other areas, and we're currently in discussions to now try this in Bulawayo. Some challenges were sharing data with stakeholders. It was not clear from the start who should have access to this data, and so that involved some conversations to smooth that over. There were transport issues to make sure that with fuel shortages and vehicle issues, making sure that the teams always had a vehicle to go out. And then one challenge was really thinking carefully how we could ensure the system could last even after the outbreak ended. So that involved a lot of conversations and thinking about who should be involved and who should stay involved. Okay, so now I'll move on to our next case study. And the previous example was one in an outbreak setting. And this example is in a setting where a water quality monitoring system was set as a preventative measure in an area with cholera hotspots. And so this work was done in Zanzibar. And again, I want to acknowledge everyone on this slide who are very involved with this work. And our partners for this work are the Zanzibar Water Authority, which is ZAWA, the Ministry of Health Zanzibar, and UNICEF. So Zanzibar has experienced 18 major cholera outbreaks since 1978. The latest outbreak ended in July 2016. Zanzibar has been very active on their cholera elimination plan and has identified cholera hotspots and is working on this plan to eliminate cholera. Our water quality monitoring project started in August of 2021. In 2021, the water utility estimated to supply 60% of Zanzibar its water. About half of this water was chlorinated. At that time, there was no regular water quality monitoring system in place. As I mentioned earlier, this is a collaborative project amongst a few groups. The objectives of this program were to create and implement a routine water quality monitoring system in districts with cholera hotspots. And the focus was on the chlorinated networks, and it was meant to be a preventative measure to see if we could make sure that no outbreaks would occur. The methods included mapping all ZAWA treatment tanks and storage tanks and selecting sampling points throughout their pipe network. These included near the treatment tanks, further down the pipeline, and at the ends of the network lines at points of consumption in households. In 2021, we started in the 5 districts with cholera hotspots, and we sampled points weekly for both free residual chlorine and turbidity. We had started using Kobo and Excel, and eventually we also moved to M-Water for this project as well, with the option of having dashboards that were updated quickly. In 2023, we expanded to all districts of Zanzibar with treatment tanks, which is 10 districts, and our sampling points increased to 86. In 2024, just last month, we mapped 18 new treatment tanks that ZAWA has recently opened, and ZAWA, after this most recent expansion, will estimate to supply 80% of Zanzibar's water. So the dashboard for this system summarizes data both quantitatively and spatially. There's a chlorination summary of all treatment tanks that the technicians and engineers can look at to quickly know what's going on in each one of their tanks that they're treating separately. And alerts are made when FRC levels are too low or at the treatment tanks or at community sampling points. The regular monitoring identified issues in the distribution system. Most often, it flags infrastructure issues such as pipe bursts, HDH shortages, and dosing challenges at different treatment tanks. This slide goes over some of the results over time. It took about 7 weeks to start monitoring in the 5 districts initially. At the start, about 25% of the points that were sampled had FRC of at least 0.2 milligrams per liter. We next worked to increase the number of samples that had at least 0.2 milligrams per liter, and that took approximately 12 weeks. Next, we tried to increase the number of samples that had at least 0.5 milligrams per liter, and that took about 28 weeks. We then hit a bit of an HGH shortage around week 37. So the results, there is a clear dip when that happened. But by week 70, more than 90% of points had at least 0.2 milligrams per liter. And by year 3, which is what we're in now, 100% of points have at least 0.2 milligrams per liter, and about 50% of points have at least 0.5 milligrams per liter. So in summary, the monitoring led to improvements in chlorination. We observed increases in FRC over the 3 years. The mWater dashboard has quickly identified corrective actions, and we're presently expanding the system to include 18 new tanks. There's now interest to replicate this in other areas in Tanzania, and we will continue to help with that. Some challenges included that some treatment tanks use manual chlorination, so required additional monitoring. There's also an issue of sustainability. In Zanzibar, water is traditionally provided for free for religious reasons. So there's been a bit of a transition as ZAWA started to introduce metering to try and make this a more sustainable model. Transportation was also a challenge due to the getting to all parts of 2 islands. So motorcycles were purchased for this project. Some key lessons learned between the 2 case studies. The first one is to take advantage of an outbreak to promote water quality monitoring, either during the outbreak response or after a large outbreak to introduce a preventative water quality monitoring system. The second is to ensure all stakeholders are involved from the start so that everyone can work together and are on the same page from the start. The third is to keep it simple, at least at the beginning, and then expand as needed so that you can make sure you have all your ducks in a row. And what we did find is you likely need seed funding to start these types of programming, as it's very hard to do without any startup funds. Thank you. And I'm now going to pass it over to Tom, who's going to discuss some of the upcoming toolkits.
Okay, thanks. We're almost done with the presentation side, so it'll get a little bit more interactive shortly. I'd also like to give a shout out to Ryan Schweitzer and Andrea Martinson from our team, who did another one in Zambia during we had a big outbreak in Zambia this past year, and they also implemented. There'll be a poster session on Thursday evening, so get a glass of wine and go ask Ryan some questions, please. We're going to talk about 2 toolkits that were developed to sort of carry on with this work. The first one I'm going to talk about is the water quality monitoring for cholera. So cholera specific toolkit, and this is to be sort of how to operationalize water quality monitoring in response or as a preventative measure before an outbreak starts. This is a collaboration between CDC and the Global Task Force for Cholera Control, the WASH Working Group. And I know there's several people on the task force in the WASH Working Group who are here today. But this has been identified as a high priority for this working group. The Global Task Force, for those not aware, is a global strategy to work on the reduction of cholera transmission, not only reactive to outbreaks, but to try to deal with the underlying issues. And that's a big piece of that is WASH. As you can see, it's been identified as one of the top priorities for the WASH Working Group. You would think that in a cholera outbreak, there would be a large focus on chlorination and monitoring. It's a waterborne disease. But for those who've worked in outbreaks or in humanitarian emergencies in general, we often see that it's not done well, not timely. It's not prioritized with resources and manpower. And it's also not systematic, that it's done in some cases haphazardly or not randomly, but not systematic. And the key point that Anu raised earlier, the data that's collected is often not used for corrective action. we also know that there's lots of guidance documents on water quality. There's plethora, and actually we developed a water quality guidance document because everybody does that. But what we came out of this as we started interacting with other groups and with the Global Task Force and with ProWash and Scales, what we really need is more of a toolkit and operational. So we've kind of adapted that to keep the guidance, but actually work on a toolkit that can facilitate operationalization of water quality monitoring in emergencies and in cholera outbreaks. So this toolkit will be focused on cholera. It's to be used either in response or preparedness. And the goal is to facilitate implementation in water quality monitoring to enable timely corrective action. That's the key thing we want to get out of this. It's intended to be a how-to guide, step-by-step implementation guide. And we're trying to draw from experience that we've had and others have had. And we would love to draw on other experience that could feed into this. So it's not a done deal yet, and we're still looking for input. We're working on a current version, and then we want to update it as new examples become available or changes are made that lessons are learned from implementation. So this is kind of the structure of the document that we're working on. It goes through some of the basics of water quality monitoring. It goes through standards and thresholds. What are the key parameters? Focus mostly is on, as mentioned, is mostly on free residual chlorine, maybe turbidity, E. coli, total coliforms for microbiological sampling. Trying to keep it simple. Certain cases, like in Bangladesh, you might want to do tests for iron, manganese, et cetera. But you're not adding lots of parameters that may not be necessary in an emergency response. And then working on a description in different contexts. And then build into that, we would have case studies, which would describe step-by-step process with examples, similar to what Anu just presented. So this would be kind of the overview of the different steps. You would identify, make sure you have a clear objective. So not just to do water quality monitoring, but you have a purpose and how the data would be used. We needed to select what type of water source will be used and what are the tests that are going to be conducted, key decisions that need to be made early on. We need to decide on what are the sampling sites going to be. So there's a plethora of a large number of sites. How do we strategically choose which ones need to be sampled, or might be a random sampling, but that decision needs to be made early on. We have to determine how frequently we need to sample, daily, weekly, monthly. Will it change as the monitoring system gets in place? We may want to include a sanitary survey, and then we want to collect data in a way that can be used quickly for corrective actions. The step-by-step would also go through different types of sources. So a pipe network, like Anu presented, boreholes, hand-dug wells with or without inline chlorinators, others without treatment, which might mean microbiological testing. We also need to include household water storage, which is the common response in cholera outbreaks. How do we monitor post-distribution to see whether it's actually the products are being used and used correctly or not, and whether people know how to dose them. And then also on institutions, schools, healthcare facilities, other institutions. And then these case studies would use examples similar to what we captured from the two examples from Anu, going step by step on how it was used in these examples. So some of the proposed case studies would be a centralized pipe system, borehole monitoring, water trucking monitoring, household water treatment, bucket chlorination, so point of collection, disinfection, and then at institutions. We've have two of those completed now, and we need to fill out the others. So if anybody here has great examples from the non-bold ones, we would love to capture that as well. And so next steps, we are now working with an instructional designer on second iteration of this, which will then be shared back with the WASH working group for comments and edits. We're then we want to have two pieces, a PDF version and an online version that people can just download. And then we want to pilot it in a few locations to see if the toolkit itself will help push forward and help to facilitate implementation, or something else is needed. And then once we finalize meaning a usable version, which will be updated, we'd like to get it translated so we can use it in different languages. We'll then have some review being done by implementers, and then we'll work to adopt another one, which will be talked about next on emergency settings, non-outbreak settings. So quick overview of this toolkit that's being developed, and we would love input. And now is to Nicole.
Great, thanks so much. So I didn't introduce myself earlier. I'm the WASH Technical Director for ProWASH and Scale, and our big focus is capacity strengthening learning and research. So on your table, you might have some examples of products that we previously developed. And so we want to get your input now on some of the products that we could develop to help address some of the gaps and challenges identified through the case studies. So earlier in the AHA poll, half of you said you wanted to learn about kind of what's happening in the space, research, and then the other half wanted to know about tools and guidance and templates. So that's where we're moving for the rest of today's session. So I'm going to ask you to join me on the same QR code on AHA slides. And we want to hear from you. What do you think would be the most useful? You'll have a little ranking exercise. Do you think it would be helpful to have water quality monitoring planning guidance for emergency context? Have an online version that would be with short videos, but also links to templates and good examples, a water quality monitoring cluster coordinator toolkit, which would help clusters set up water quality monitoring planning in the first month of a response, data entry templates, database and dashboard templates, or water quality monitoring planning matrix with completed examples. So I will ask you to join me on that same QR code. And let me show that to you. It's also on the tables. Yep. There you go. Oh, great. We have some early voters here. And for those of you online, you can vote or you can drop it in the chat box and our colleagues will note down your preferences. Oh, there we go. Anyone need a QR code or trouble accessing it? Still voting. As Christian mentioned earlier, we've pulled together an annotated guide to emergency drinking water quality resources. But if you're aware of other examples of good tools, templates for water quality monitoring, we're always looking for more. So if within any of these categories or otherwise you see examples, please send them our way. So I'm seeing that there's a lot of interest in database and dashboard templates, followed by planning resources for clusters, then the water quality online guide, and not so much some of the other categories. So good. So we are going to move into small groups shortly, and we'll have about 6, 7 different groups. And so we want to hear from you. What would you like to discuss in these small groups? Data management, privacy and ethics, capacity strengthening for water quality monitoring, roles and responsibility of stakeholders, linking data to corrective actions, making the transition to routine monitoring, community engagement and risk communications, and adapting water safety plan to emergency settings. And so really these small group discussions are an opportunity for us to draw on the collective knowledge and experiences that are in this room to feed into the toolkits that both Tom mentioned, as well as these job aids that we're considering developing in the next year. And so as you continue to vote for these small groups, I want to note for those of you online, our colleagues Katrine, Tori, and Andrea are online, and they'll be with you in a Google document. Unfortunately, you can't speak together using your voices, but you can type together in the Google document. Sorry for that. So as you vote, we have time just to take a couple of questions that you might have on the case studies or the toolkits. Any questions in the room or online? When is the toolkit expected to come out?
So we hope to have the next version by the end of this calendar year. If everybody in the working group agrees that it's ready to go, and then we hope to pilot in a couple of locations starting next year.
Yes, please.
Yeah, Mark Johnson, University of North Carolina. So the monitoring uses for the people indicator call, but there's no monitoring directly for culpable video quality. How come? There are new tests available to do that are open access. You can get results from the cholera test the next day.
So for those online, the question is, we monitor for free residual chlorine, also for bacterial indicators, E. coli, fecal coliforms. Why not monitor for Vibrio cholera, since there are newly developed tests which can do that in some cases quite frequently? So this has been a discussion. Discussion has been going on a lot within the cholera world, within the Global Task Force for Cholera Control. There's been a statement issued on sort of the pros and cons of including or prioritizing Vibrios. The statement is not saying it not to include Vibrios, but for routine water quality monitoring, where the water, for example, where the water is supposed to be disinfected, we want to ensure that the water is safe to drink. So the easiest way is to monitor for free residual chlorine. So we don't need to test pipe drinking water for Vibrios if we can just assure that the water is actually treated. If there are locations which epidemiologically might be suspect for testing for Vibrios. For example, we get cases clustered around a particular water source. We may want to test for Vibrios in that circumstance to add evidence. And so there might be circumstances. There might be places, say, for example, in Haiti, where we had 3.5 years with no cholera following a huge outbreak. Would there be a purpose in monitoring for Vibrios in the environment to see whether it could return? Would that have given us any? For those who don't know, there was a resurgence after 3.5 years when Haiti was almost at the point of saying there's zero cholera, but it did come back. If we had some kind of monitoring in place, could we have picked it up earlier? There's some circumstances where it might be used, but in terms of outbreak response, the primary focus is on let's treat as much water as possible. So the goal is to maximize treatment of all drinking water supplies during an outbreak, and that means chlorine residual testing. E. coli tells us that it might be at risk for Vibrio contamination, also at risk for other fecal contaminants as well. Whether we include Vibrio more routinely might change over time, but that's been sort of the stance so far.
Thank you. I see there's more questions. We are going to move to the small groups, but all the presenters are here for the rest of today and several days this week. So we see a lot of interest on linking data to corrective action, 29 votes, almost all of the categories besides data management, privacy, and ethics. So I'm going to go ahead and announce where the different groups will be and who your facilitator is. So that way you can find your person. Good. So linking data to corrective action, we are going to have one table up here with Tracy. Tracy, raise your hand. And then the table right behind will be linking data to corrective action with Christian. Then we have people interested in capacity strengthening for water quality monitoring. So you'll go with Tom, and that will be this first table up here. Behind that, you have roles and responsibilities of stakeholders, which will be with Precious. So right behind at the next table. Then you have making the transition to routine monitoring with Anu. And you'll go behind, so in the chairs back there. So follow Anu if you're interested in making the transition to routine monitoring. You'll be with me on community engagement and risk communication in that far back corner. And then finally, we have Ryan with adapting water safety plans to emergency settings. So we have about 20 minutes. Again, we want to hear from you on your experiences, give us feedback and input into the toolkits, and then we'll do a brief readout in plenary. Yes, in the back, yep.
Building here?
Yep.
What about the online group? Did we give them a category or
With who, sorry?
online?
They have a shared Google document online. Yep. So this one is just, we have 2 groups on linking data to corrective action.
Come in here. I don't know where that, I'm Sean. Are you with PHA as well? Thank you.
Yes, okay.
Stuart.
Building. That's one way to get out of it.
Yeah.
Read on what the other 2 key takeaways. So.
So one of the ideas is developing decision-making grants. Will be present.
And I'll say,
Which is, I guess, a small challenge. Yeah, so try to think outside of that, place where we're tolerant for it. Yeah. So we try to address that. Some of the part of it is getting the right people who know how to do it. It's not just sending something. But also who decides where to sample from? Who decides how quickly there's capacity for those people? The decision makers, not just the field. You're going to sell and water. Make that decision.
Well, then there's something on the system itself.
Yeah.
Just like,
So what?
and ensuring that they have or something they can look at what they want to.
Exactly.
And permission, right? And permission, right?
Yeah.
And like if it is a true emergency situation, like officials have to like grant permission, right? For folks to be able to be in.
If you were thinking about it,
So I think that's where the thing is, it's like, we already know that with like independent of water quality testing, but in trees. So getting any right, so you're preparing the, whether it's like, yeah, like, you know, that if you go in with the right, and so similar, if you're applying out water quality testing, it's starting to have how far in advance are we interested in everything?
I don't mean to say, thinking about who we target, what we want, what you're thinking.
Like how do you approach community? What people willing to get that training and be engaged with?
Well, who's that? Who you train? Or is it the population or is it maybe the environmental health?
Tell you what my approach would be. I would do it, I would open up as broadly as possible, introductory to water quality. And do it differently online. I would do like introductory and then out of that, then that cohort gets invited to, those get invited to. Yeah, at the same time, you're gonna be targeting specifics. Well, but. And a lot of times, yeah. How many people are already 3 months in advance designated to focus, and that's part of their job.
Some places
To where I can say, on this exact, on water quality testing, almost exact example, and it's connecting dots to people who are already trained previously. And Zambia, there was. That's my memory to what the actual outbreak was, but there's an organization that is very strong in water quality testing. So they for the wash cluster to be able to tap into skill set of that organization. So they're not necessarily, and they don't want to. So I don't think it necessarily is only like if there isn't somebody does it, then you're trying to decide what brings us to an answer. We had that type of
That could be there.
Yeah, so we look at. Let's say. Your team go there, somebody says, nobody's so therefore. What would be the final? Same way you. We think we're training program. And you have to develop. Guidance. Outbreaks rely more on. Yeah, well, relationships.
I mean, you're a large organization.
Yeah, we have about 10 countries with wash projects, and we're trying to incorporate water quality monitoring with our trained but we rely really heavily on pro washes, technical water quality training guides. Yeah, we're at that introductory stage. Just
So anyways,
routine.
So here's why I go to like training, and is just 2 months ago, an organization, we can say one in Zambia, did their first online training in water quality testing. They had 100 people registered for 30 options. And 77% which is outstanding because with industry norms are resources. And so there's people out there, I haven't looked at which one I think, but those are where I live, and this is why I get ahead of the game as much as possible and make it open and start having where those boards are. Because then you are ready, at least they've taken the factory. And then it would be easier, let's say, as one of your countries, it's like, okay, I'm just taking that out online. And you have to go in 3 months, we want to get a subset of them, and a subset of those are government. There's the list of the small groups.
How do we build that second capacity, either to repair or respond to the acute emergency. Those out there already are responding. What's the call?
You say the priority is the topics or the.
I say the priority is to build a basket. Whether it's going to be and that is if we in a toolkit with these kind of step by step. You think that's not solving more. All of the gaps are explain how to implement and then see how
So,
yeah,
There's a lot of toolkits on a cell.
so I guess you already know. Searching. And there may be opportunities for response programs. So like that sharing is a thing on the field. Standard test, which is multi-step, multi-test. So then you do that. Let them try something new like this. How does it be better?
Even if we included the toolkit, we're enough to facilitate, we need to send our people to feel regional office or where people can get all the material there. This is what you how you decide of all the different sources we prioritize. That is not.
Right? Like, if they're trained and educated, if it was me who knows something someday and haven't done any water testing in 30 years, I can also right because I can have that, but then I want to have access to somebody. So I could probably still do it with somebody skilled in the country.
Data sharing.
Yeah, if that's the target audience, then yes, I think because.
We gave them similar.
Yeah. I don't think you can, well, if they're already strong, but if it's.
Could be one of them.
Like if it's like health workers, but if it's somebody in the utility that's already used to, then yes.
But it might not even involve. It could be water trucking. So we've had many cases where water trucking and some are getting. Some are getting.
Utility has not done in their own teams, then that's a new that's like how to think about the network and the slide or the pipe slides, how they overlap. That's it's just a different way of thinking, right? And so I do think there needs to be more.
And I think too, like depending on the outbreak or whatever you're dealing with in an emergency situation, the health ministry is kind of the lead agency, right, for that response. Is that, I don't know, I'm really. And I didn't know how in those meetings, in the day to day, like if they have.
It's coordinating well, if they're coordinating well, they.
Well, I just think about.
This is not college specific, but I'll give you a current example. Here in North Carolina, so the Northern Carolina, you know that tremendous storms, flooding, wiping out all the water. It's basically gone. Also, all the private wells that are not regulated by the public. Understand what that is, which there are. They're following the testing for us. Even if it wasn't previously held, that's also. So, Hydrogenics is contacted by public health services. Give us that water from a certain way. so that we can get wells tested. Maybe have people do well testing themselves. Because they're doing that. You get at ambient temperature. We said, sure, so we don't. But that's an example.
You're right in the backyard.
Substantial.
The third question, yes, we only got a couple minutes on to wrap up, but do you have any examples of effective training or class training program? You have them for water quality monitoring or just in general, that might be suitable. Think about how to use this. So anything, you have any examples of passages around water quality? Emergency response. Okay. Yeah.
Although it's water quality testing, not so much water quality monitoring, it would have to be adapted. But,
So for non-outbreak situations, they wanted maybe increase the more testing. You all you have the resources to surveys, not emergency centers.
that's your specific emergency.
Yeah, but it has to be grabbed from others that we can adapt.
Do you know how have you written on how the training's been going on to the dam? Like, I know that they've like had several trainings around the world. You know, how was it?
I'm not sure. It's a good question. We're supposed to wrap up. Could we need to wrap up. If you're at your session, let's take one more minute and then we'll have one person per group summarize for the group.
And the audience matters. Yeah, like you'll use it higher
Training modules. Some of our countries need more hand holding. Totally the online patient we really. We go do trainings in person.
Oh, so here's an example of Venezuela, one of the things we did is adapted to what happened. Didn't have, we had a to find out what hundreds could actually have digital. Did like many modules, like many modules on WhatsApp, on
So we gotta wrap up. Gracie, is everybody ready? Can we go to plenary? We've only got 10 minutes left and we want to capture. Okay. So what we're going to do, we have 10 minutes left. We're going to go group by group. And if you could give us, there'll be one person, you can change who that is, but we'd like to get your top one or two bullets from your group, introduce what your session was and any key takeaways. Please, if you took notes, capture those notes so we can keep them afterwards, but we want to feed back to the group a couple of key points. So I was sitting with this group here and we were working on capacity strengthening for water quality monitoring and thinking about how to build capacity. And I would say one of the key takeaways was if we could do this before an emergency or before an outbreak to do some of the capacity building, even if it's not perfect, even if it's not context specific, to start identifying who the key people are. How would you build on the coordination between the utilities, between Ministry of Health, Ministry of Water, the UN organization? If that could be done in advance, it'll make it much easier to introduce an emergency water quality monitoring kit exercise once the emergency happens. So as much as possible, think in advance and try to go through those key things of identifying the key people involved. What are the resource gaps? What do I need to do if it was implemented? So if you could do that in advance. Another question that we addressed was, is the toolkit enough? So if we have a great toolkit, it's step by step, multiple different scenarios, is that enough? Can we make it accessible to a country and there's an emergency or they're thinking about preparing for an emergency? Can they just use the toolkit and that's enough to implement it? And I think we were kind of mixed. I don't think we reached agreement on that. It's context specific. Well, I don't think we reached an agreement that whether that's a standalone is enough or not. And hopefully that's the purpose of doing a pilot. We'll see whether it's enough or not. Anybody want to add anything to that, or did I summarize this fairly? Okay, cool. Okay, so that was group number 2. Who has data management, privacy, and ethics? We didn't do that one. Okay, great. Roles and responsibilities of stakeholders. Precious? Yeah. You might need to. Yeah, we have people online though.
I have to say that Precious led a lot of this discussion because she's been doing this for over a decade and she's done it from both sides, both the NGO and also from the donor. So I think the 3 main points that she wanted to bring across, certainly with regards to roles and responsibilities, was one, like the previous group, was ensuring there is coordination of all stakeholders, but more importantly, mapping out those stakeholders prior to this activity, prior to any response to this acute emergency. The other point that she wanted to bring across, and this was using her examples of her working in Haiti, responding to the 2010 earthquake in Haiti, was ensuring that the community is involved from the beginning. And it's not just as recipients or beneficiaries, but actually participating in monitoring, ensuring that they're part of this, of any response. And then the third point, which was it's very linked to that second point of inclusion of the community, was ensuring the monitoring is in place throughout that process. And the example she gave was looking at the supply chain, looking, for example, of, the trucking in of water and realizing that it needs to be monitored from collection to distribution to the end user. They had instances where there was a typhoid outbreak because the trucks that were transporting the water were actually contaminated. I think that's it. Thank you.
Thank you very much. Okay, let's go to group number 4, linking data to corrective actions. And
All right. Thanks, everyone. So we have the benefit of a flip chart up here. And so first we kind of talked about how we might want to have frameworks in place so that we don't have to reinvent the wheel every time. So we wanted to start with kind of utilizing existing utility frameworks. We know people have thought through these before, and where can we take them and adapt them to kind of our emergency context, really focusing maybe on some of making them less complex, focusing on some of like the quick wins and key parameters that we could include in those plans. We did think that we needed to look at kind of the scale and context. So whether this was something that needed to happen at the systems level or kind of the infrastructure and materials level, but also making sure that we don't forget about the behavior side of things and where some of these actions might be tied more to the user behavior, and kind of looking at those two different pieces of work separately, because they do have some different actions that need to be taken depending on which type of challenge you're dealing with. We thought we could obviously use tools such as logic trees and making sure that we utilized data that was already existing, that had been already collected, and making sure that we are looking at this in terms of public health risk. So, again, kind of which key parameters are we looking at, especially in emergencies? We want to be looking at things that are really kind of a very immediate public health risk in prioritizing those versus maybe some of the other issues that are important but might be more chronic. And making sure that we really thought about both transparency in those frameworks so that people can understand what's being monitored and why, and making sure that the language was accessible so that these sorts of frameworks are accessible not just to the emergency WASH experts who think about it all day long, but to other people as well. We talked about barriers, and I think, we're great at identifying barriers. And so we talked about misinformation and lack of capacity or training at different levels. We heard about some of the supply chain issues in the examples that were given. We also talked about things such as like bias, where government officials or an implementing agency might feel like they didn't want to report bad results, they might get in trouble. We talked about barriers being levels of decision making. So if the data collector isn't empowered to make any decisions or take any action, then that's going to slow things down or be a barrier to actually taking action, and just kind of the layers of communication. And there was finally a point on people feeling that monitoring is passive. So we monitor the data, we don't have to do anything with it. And so maybe we even need to look at our language and how we frame this. Instead of calling it water quality monitoring, is it something like water quality assurance that might make people feel like it's a more active thing. And
10 seconds.
okay, and then to be fast, we are going to have more automatic on-the-spot flags to increase speed, let decision-making closer to the ground, local involvement from the beginning, and triaging and prioritizing actions. So there you go. Very easy.
Great summary at the end. Okay, we've only got 3 minutes left, so I'm going to ask each group just a minute max.
We were doing the same topics. I think we can move to the next one.
Did you have anything new? Anything addition you want to add to it, or?
Sure. How much time you got?
15 seconds.
Well, I guess to add on that, there was around the value of bringing stakeholders together, the importance of having a coordinated plan from the beginning, and therefore the role that potentially clusters could play in that. And also highlighted the value of a tool such as the SWOT, which is action orientated from the start. So that links a little bit to what Tracy said about is water quality passive. Like in the tools we use so far, if it's a Kobo or an Excel, does it end in that column of result? Or are we structured and thinking about results and how to action it from the start?
Great, thank you. Okay, let's go to group 5, making the transition to routine monitoring.
Okay, so that's our group. So we had a very innovative conversation about this. And the first thing that someone mentioned, or a few people mentioned, was the use of remote sensors, as that would then allow us to not have to make this transition to routine monitoring. But we also discussed the current cost barrier. So maybe that's TBD as we wait for the costs to become more affordable and to be used more widespread. Some other ideas including citizen monitors as part of your workforce so that you're more able to get more data in quickly from around the community rather than just relying on technical staff. Making sure there's financing for continued support even after an emergency so that routine monitoring could continue. And then the other two key points were to ensure that from the start that you have thought about this transition so that plans are made from the start to make sure that any monitoring that starts can continue after the emergency. And then community engagement. So if the community thinks it's an important activity, perhaps it's more likely to continue as well. Anything I missed? No?
Thank
We're
you.
good.
Let's go to group 6, community engagement and risk communication.
So thank you to the group in the back for this. So really key to find the specific person who's a key trusted messenger. Find also people that can reach a large group of people. We need to make sure we return data to communities, but pair that also with the actions that will be taken or how they can take action. Be mindful of culture. We talked a lot around culture and trust, and the need to understand misinformation, disinformation, as well as perceptions. Also from the online participants, I want to note that they added that it's really important to be calm, to support over communication from water authorities. So more communication is better than less. Be really clear about next steps we're taking and avoid blame shifting, silos, and being passive. So thank you to the online participants for sticking with us. Because our group is the community engagement group, I also want to put in a plug to please scan again the QR code before you go to sign up if you want to be engaged in the next steps on all of these toolkits. So yeah. To the last group.
Okay, the last group is on adapting water safety plans for emergencies.
Okay, great. We were a very small group, so we had lively discussions, and we were tackling this issue of whether or not water safety planning was appropriate for emergencies and therefore whether we should be adapting them. I think across the board, we all agreed that water safety planning as a concept and the concept of risk mitigation is a good thing and therefore useful if it already exists prior to the emergency. And so using that as a tool during emergencies. However, the appropriateness of starting that process because of the complexity, the number of stakeholders, it's time consuming, it's bureaucratic, it's slow, that may be a challenge, a considerable challenge in emergencies. And therefore we discussed the concept of having condensed or light versions, a compendium, perhaps including decision trees, looking at a phased approach where maybe you prioritize immediate actions and things that you can kind of phase in as the emergency transitions. We also talked about this issues and challenges around how this would be funded, considering the competing priorities during emergencies and what will be measured in terms of the implementation and therefore the impact on this. And perhaps in discussing whether or not there was any best practices, there's not obviously been so much application of water safety planning in emergencies. And so maybe a dearth of evidence around that, and therefore the need to generate evidence, to do studies, to see if this is something that should be implemented. But again, the concept of identifying, assessing, and mitigating risks as a positive thing that we should be trying to do, but however, maybe in a expedited way during emergencies.
Right. Thanks for that.
Anything else
summary.
to add? Sorry.
Okay, the clocks are a little bit off. It's actually only 3 minutes past, so we did pretty good. If you'd like to be involved, to follow up, participate, offer examples, pilot, please scan and send us your information and we'll include you. Just like to say thank you very much for everyone for participating. Really helpful for us. I hope it was worthwhile for you. Can I just ask, as you leave, since there's going to be another session here at 3:15, if you could just help move seats around a little bit to get it back into rows, that would be appreciated. Thanks again.